Perfect. Thank you very much. So hi there, and thank you very much for attending our talk, especially to those in the audience who contributed to the Virus Watch study, especially if you are a participant in our study. We thank you very much for coming. I'm Vincent, and presenting with me is Dr. Sarah Beale, and we're hoping to give an accurate introduction to the Virus Watch study on behalf of our chief investigators, Professor Andrew Hayward and Professor Robert Aldridge. So before I start, I think the ONS team already said we suspect many of you will have questions, which we kindly ask you to leave to the end, and we'll try our utmost best to answer them. I think this is being recorded and is posted online afterwards, as previously said. So you may not want to disclose personal or medical information when it comes to the interactive parts or in the chat as well. So welcome to our talk entitled Virus Watch, Understanding Community Incidence, Symptom Profiles, and Transmission of COVID-19 in Relation to Population Movement and Behavior, which, with the help of our participants, has recently won the People's Choice Award at the ONS Research Excellence Awards. Before I continue, I must admit that I currently have an infection, so I apologize in advance for not portraying the Virus Watch study as well as I could. Could I kindly have the next slide, please? Thank you. So I guess the big question is, what is Virus Watch? The technical scientific term for us is that we are a household community cohort study that investigates COVID-19, and we have just under 60,000 participants across England and Wales. What that means in practice is that we recruited outside of healthcare settings, such as hospitals or care homes, which have a specific set of healthcare needs by themselves. So by recruiting from the community setting, this allows us to gain some insights on what we call the general population. And we did kindly ask that whole households contribute, even if it's a single person household. And that was important for us because it helps us understand transmission. So our core cohort, known as Study 1 up there, consists of 58,000 individuals from 26,000 households who completed weekly surveys online, with occasional surveys being sent out, and who we also linked to COVID surveillance, hospital, and mortality record data for the period 2020 to April 2025, so just this month. A small part of this group also contributed to our GPS movement tracking study, which comes with many challenges, but also a wide range of opportunities, which we're very grateful for. A part of that is Study 2, which is what we call our laboratory subcohort, consisting of 7,000 individuals who agreed to provide in-clinic blood samples, with a baseline sample being collected in October 2020 and a follow-up sample being collected in August 2021. We then expanded our blood collection efforts with our antibody testing subcohort of 20,000 individuals, which helped us collect monthly home finger prick micro blood samples through these collection kits via the post, and this ran from January 2021 until March 2022, although towards the end of that study, the collection frequency became every other month. And finally, in January 2023, we started a short 6-month genomic study which sequenced PCR test kits at the household level if any individual in that household had a positive LFT test kit. And we'll go through all these in detail over the next few slides. Can I have the next slide, please? Thank you very much. So that at the core of the Virus Watch study is our online survey, where all participants can contribute safely from their own home. Our initial round of recruitment consisted of a random sampling technique across England and Wales. After our first wave of recruitment, we iteratively conducted targeted recruitment strategies with funding from Facebook and Meta, and this contributed towards Virus Watch's rough representation of the English and Welsh population in terms of gender, ethnicity, deprivation, and geography. In total, we recruited over 26,000 households and consisting of over 58,000 individuals. So during registration, we had a baseline survey which collected data on basic socio-demographic details and baseline clinical characteristics. And then every Monday afterwards, we collected data on new symptoms, vaccinations, isolation, and other COVID-related information that can change through time. So as of this past Monday, the 30th of March, 2025, we sent out our last weekly survey. And for some households, this encompasses nearly 250 weeks of follow-up. So just under 5 years worth of voluntary data submission. These surveys have been the backbone behind all of our work. Using this data, we created cohorts, had inclusion and exclusion criteria, we defined exposures and outcomes with longitudinal follow-up. Excuse me. So we thank all those who contributed to our weekly survey, those in the audience, those at home, those who are no longer with us. Your contributions have made such a big difference during the pandemic, and I do apologize for any technical issues any of our participants may have experienced with our survey platform. Could I kindly have the next slide, please? Oh, thank you very much. So moving on, we had a laboratory cohort which collected blood samples in October 2020 and a follow-up sample collection in August 2021. This was really important to us since October 2020 was before the deployment of widely available testing. So it allowed us to have a glimpse into who has been previously exposed to SARS-CoV-2, so we could appropriately account for this in our work. We invited 10,000 individuals to come to one of our many clinics surrounding England and Wales. And for some individuals, we were very lucky to be able to get a traveling phlebotomist or nurse to come to their house to help us collect their blood samples. So this work was supported by our funder, the National Institute for Health and Care Research, and their clinical research network, which consists of clinical staff such as nurses and phlebotomists. Up there, we can see the team from the Kent and Medway NHS and Social Care Partnership Trust getting ready to collect our blood samples for us. We thank them, and most importantly, we thank the 7,000 individuals who took up this offer, especially the children who bravely contributed their blood samples, which are currently stored at the Great Ormond Street Institute of Child Health, in case we need to compare blood samples in future pandemics, which fingers crossed will not be anytime soon. This portion of the study was one of the most difficult to do. Firstly, we had to try and map individuals to their closest clinic in a trusted research environment, which doesn't have any internet connection. So I do apologize for those of you who had to travel rather far. And then on top of that, getting people moving around during a pandemic for research was very tricky. And in fact, one of our hospital sites had to cancel all research activity for a few days due to a declared emergency shutdown. We're really sorry for any inconvenience that this caused. It was out of our hands, but we really do applaud our clinical team who powered through and for our participants who contributed their samples. Could I have the next slide, please? Thank you. We then moved on to one of our biggest studies, the vaccine efficacy study, which ran from January 2021 until March 2022. In this study, we were funded by the Department of Health to work with private solutions to collect microcapillary samples to be analyzed for both vaccine-induced and natural infection-based antibodies. This was extremely important as it helped us understand the difference between natural infection and vaccines, as well as the different types of vaccines and how long antibodies could last. Overall, I thank those participants who contributed and allowed us to collect over 100,000 samples, especially as it was not easy or pleasant to have your finger pricked every month, or even administering the finger prick yourself, which can be scary. My own results came back inconclusive due to the fact that I have thick skin, so I do apologize for any inconclusive results. However, I do promise that these were very useful, and my colleague, Dr. Sarah Beale, will present in a few slides what we did with these samples and how it made such a big difference during the pandemic. This part of the study was logistically challenging, as we had to send thousands of kits across England and Wales, but we had help from a logistics company, Vision Logistics, as well as Thriver Labs, to conduct the tests. Sometimes we had to resend the kits multiple times, and despite all these challenges, this part of the study was very rewarding. Can I have the next slide, please? The final study I'll go into is our genomic study, which we recently conducted between January 2023 and June 2023. In this study, we invited 3,000 individuals, primarily from multi-person households, to submit PCR tests when at least one individual household had a positive LFT test. With help from the Camellia Botner labs at the Great Ormond Street Hospital, our laboratory scientists extracted information on variant and where two or more positives in the same household were part of the same infection chain, and we are hoping to publish on this work very, very soon. Can I have the next slide, please? This is the penultimate slide before I pass on to Dr. Sarah Beale, who would get a bit more scientific. On top of these components of VirusWatch, we also have occasional surveys, which were previously monthly, which we developed to capture the ever-changing psychosocial and clinical landscape during the pandemic. For example, when the vaccines were initially deployed, there were priority groups for those who could receive this. And we used our occasional surveys to capture information that allowed us to make fair comparisons when looking at vaccine effectiveness. We also used our occasional surveys to investigate what many would call long COVID, which is one of Dr. Beale's areas of expertise. One of our colleagues, Dr. Isabel Braithwaite, investigated the disproportionate impact of the pandemic on those experiencing a disability. So thank you very much to all our participants who contributed towards our occasional surveys. A proportion of our cohort also installed an app on their phone, which allowed us to track their movement, and this was really helpful to understand the effect of lockdown on essential travel. Understanding movement was very important during the pandemic, where we were advised to stay indoors, even though many of us could not do so due to essential work or caring responsibilities. This work was supported by the Space-Time Lab at University College, and the software and infrastructure was provided to us by the Environmental System Research Institute. And this work on movement went on to win the VirusWatch team an award, which we dedicate to all the participants who contributed nearly 200 million GPS coordinates. One of the best parts of this project was how proud one of the members of the Environmental Systems Research Institute was that they could help contribute towards our fight against COVID-19. And finally, we were able to link the VirusWatch data to hospital episode statistics and national immunization data. And by linking these data, one of our colleagues, who is soon to be Dr. Fong, one of our most talented researchers, has found that VirusWatch's estimates of infection became very representative of the national published data for a fraction of the cost of comparable efforts. VirusWatch is a small team with a relatively low budget, but we have the help of our study. But with the help of our study participants, we made a huge impact, which I'll go on to next. I have the next slide, please. So finally, before I pass on over to Dr. Beale, the contribution of the VirusWatch cohort has resulted in over 30 peer-reviewed publications with over 1,000 citations. Some of our most cited work includes work on antibody waning, the risk of long COVID in children, occupational related risks that that occurred during the pandemic, household overcrowding, and work which investigates the role of deprivation and inequity in the COVID-19 pandemic. This work has had extensive media and digital coverage, a lot of which was on antibody waning, which we'll talk about in a bit. This work has also been used by government advisors inside and outside of the UK, particularly on booster dosages. And finally, we also work with Doctors of the World and the Race Equality Foundation to provide evidence for the UK COVID-19 inquiry, which highlighted the inequities that grew during the pandemic. Now, I'd like to pass you on to Dr. Sarah Beale, who will present one of our most successful pieces of work.
Thanks very much, Vincent. That was a fantastic introduction to the VirusWatch study. And as you can see, it was a really large study in terms of incorporating many collaborative research efforts that kind of branched across many fields, including epidemiology, network science, and looking at movement, and immunological studies as well. We wanted to give you a little taster into some of the results of Virus Watch and how they impacted policy and practice during the pandemic. And in order to do this, we've picked one study which had a substantial impact on vaccine policy and wanted to give you a little bit of detail. This study is about spike antibody waning after the second dose of two prominent vaccines used in the UK. And don't worry, we'll go into all of these kind of technical details in a moment. And this piece of work was led by our fantastic clinical colleague, Maddie Shropshire, and included a lot of interdisciplinary expertise from the Virus Watch team. So to provide a little bit of background to this study, as we all know, in response to the surging waves of the COVID-19 pandemic, the National COVID-19 Vaccination Programme began in the UK, which was the first country in the world to roll out a national vaccination programme beginning in December 2020. And just as a refresher for the vaccination programme, these vaccines were initially made available according to clinical vulnerability for the general population. So that was according to what medical conditions that you had and other demographic factors such as age that made certain people more at risk of having severe COVID, as well as people's occupation. So health and social care workers also received the first access to vaccines due to their roles within the community and treating people at risk. The first vaccines that were available in the UK, as we may remember, were the Pfizer-BioNTech vaccine, also known as the very catchy BNT162b2, and the Oxford AstraZeneca vaccine, also called ChAdOx1. And both of these aimed to boost the immune system response to the virus by increasing antibody levels. Now, antibodies are produced by the immune system as a first line of defense in response to infections such as SARS-CoV-2, which is the virus that causes COVID-19. Both of these vaccines, and in fact, all vaccines that were subsequently available in the UK, produced antibodies against the spike protein. So spike is a protein that is on the surface of the virus that causes COVID, and it helps the virus to enter your cells and cause infection, and then, of course, in vulnerable people, severe illness. So these vaccines help in different ways to produce antibodies that make the body more able to prevent infections from becoming severe. And the Pfizer-BioNTech vaccine does this through a technology called messenger RNA. So that's based on pieces of genetic material that stimulate the immune system. And the Oxford AstraZeneca vaccine does this using a more traditional vaccine platform, which is the way the vaccine works, which uses a virus that an adenoviral vector, which is a virus vector that stimulates the immune system without causing an infection and allows the body to produce antibodies. So they have different ways of working, but they both have the same target. Both vaccines also had an initial primary course, so that's your main course of vaccination that comprised 2 doses. Within the trials of the vaccine, these doses were given 3 to 4 weeks apart. But in practice, during the COVID rollout, these were given further apart in order to try and maximize the efficiency of the vaccine program and stimulate the immune system. So what we wanted to do in light of this kind of rapid development and rollout of these vaccines, which was a really kind of exciting part of the COVID-19 response, given the severity of the situation, was to use our vaccine efficacy sub-cohort within the study to estimate antibody waning after these primary courses of vaccines. And the reason that we wanted to do this is because with any vaccine, we'd expect antibody levels to change over time since vaccination. But these changes can have impacts on how effectively the vaccine works over time. And this is particularly true for vaccines for respiratory viruses like COVID. So understanding this as soon as possible during the vaccine rollout was really important to continue to inform our response. So how we looked at these changes in people's antibody levels after vaccination and compared them was we took the population of VirusWatch who had participated in the vaccine efficacy subcohort. And as Vincent mentioned, this was offered to all adults in the study within VirusWatch. So the full population of people who participated was about 20,000 adults. And they provided monthly finger prick testing around their antibodies for anti-S, which is the antibody, as I mentioned, against the spike protein, which is produced both in response to vaccination and infection, and anti-N, or nucleocapsid, which is a different type of antibody, and that is produced in response to infection only. And the reason that this is important is we wanted to include fully vaccinated adults who hadn't had a COVID infection by the point of the study. And the reason that this is because we know people who have infection and vaccination have different immune responses than people who have not had an infection yet. And of course, because the vaccine program was aiming to reduce the burden of infections on people in terms of severe illness, we were primarily interested within this study in looking at people who hadn't had an infection. And so those N antibody tests, the ones that look for infection, were used to screen out people who had already been infected. Our exposure, which is a fancy way of saying the things that we were comparing within the study, were the two different vaccine types. So the Pfizer vaccine versus the Oxford AstraZeneca vaccine. And we collected this using our weekly online survey. And this was because we didn't have the linkage data available early in the pandemic. This study was completed in June and July 2021. The outcomes, so what we were interested in investigating, were people's spike antibody levels based on those finger prick antibody tests that Vincent really nicely described earlier. And we analysed people's levels of antibody in response to the vaccine using the gold standard laboratory testing process, which is described on the slide here. We used quite a simple but fairly powerful analytical method just in terms of being interpretable to policymakers and clinicians in quite a ready way for this analysis. And we did that by estimating median antibody levels at different times since completion of the vaccination course. And you can see this ranged from about 14 days to over 70 days. And so I believe the full range of duration since vaccination was about 14 days to 150 days. And this was broken down into categories. And we compared antibody levels during these periods according to vaccine type. So just to give a little bit of an overview of the final participants within the study, 605 adults submitted a valid sample on the day. So you might ask, from 20,605 doesn't seem very many. And that is because we took samples on a specific date, which was the 24 hours from the 14th to the 15th of June, 2021. And this is because, as we know, people's exposure and antibody levels and the vaccine program change quite rapidly over time. So it was important to take a snapshot. So of these 605 participants, about half were female. And you can see the median age was 63 years. And this reflected the fact that older people had been prioritized within the rollout of the COVID-19 vaccination program in the UK because of their higher risk of severe infection. Also, 31% were clinically vulnerable according to the government's clinical guidelines around what makes you at risk of COVID, and 90% were extremely clinically vulnerable, which was generally related to having a condition that severely affects your immune system. So this is approximately half of participants being vulnerable or extremely vulnerable, and again, this high level reflects the rollout of the COVID-19 vaccine. About 33% had a primary course of the Pfizer vaccine, that's the mRNA or the genetic vaccine, and the remainder had received a primary course of the Oxford AstraZeneca vaccine, which was the first-line vaccine in the UK response. And the median interval since completing their vaccine course, the primary course, was about 77 days. So there was quite a range, but that was approximately the midpoint. When we had looked over the samples, about 7% had evidence of prior infection according to that other antibody type, and those were excluded from the final analysis because, as I mentioned, the antibody response can be different if you've had an infection. So what did we find in this study? Well, as you can see in this figure on the left, we found significant declines in antibody levels in both vaccine types over time. And what this means is, as we would expect, since vaccination, people's levels rise rapidly within about the first 2 weeks of vaccination, and then they begin to drop off quite rapidly as well. So between 20 days and 70 days or more since the second dose, which is completing your vaccine course, levels of anti-spike antibodies dropped for both vaccines. But as you can see, the Pfizer vaccine, which is shown in blue here, led to much more stimulation of the immune system, which leads to higher antibody levels. And consequently, even though there was waning, levels were much higher at all time points since the primary course for the Pfizer vaccine than for the Oxford AstraZeneca vaccine. So the waning for the Pfizer vaccine was about half. So your antibody levels dropped by about half at approximately 70 days since you've completed your course. Whereas for the ChAdOx, the Oxford AstraZeneca vaccine, this dropped by 5-fold. So the drop was also much more substantial for people who'd received a primary course of the AstraZeneca vaccine. So this trend, where there was waning for both vaccine types, but the levels were higher at all time points and the waning was less intense for the Pfizer vaccine, remained consistent when results were stratified, so when they were investigated in different groups according to age, sex, and clinical vulnerability, which are all factors that can affect how your immune system responds to vaccines. So even though people may have had different responses overall. So, for example, the vaccine responses, the immune system tends to respond a little bit more intensely in people who are assigned female at birth compared to people who are assigned male at birth. The same trends of waning and vaccine response to the two types were consistent across all groups. And so, why does this matter? Well, the levels of antibodies in your blood are related to how effectively a vaccine protects you. And so the implications of these findings are that people who'd received a primary course of the Oxford AstraZeneca vaccine had lower overall antibody levels, and that for both vaccine types, we saw fairly substantial drops in antibody levels over time. This had a significant impact on our understanding of the vaccination program within the UK and beyond the UK. And most substantially, this contributed towards the evidence for the need of a booster dose of vaccination, since we saw that people's antibody levels, as you could see, were dropping off rather quickly. And it was too early in the pandemic to fully understand the implications of that. And so because we need to prioritize protecting people, this contributed towards evidence for people needing an additional dose of vaccination. Also, given that the Oxford AstraZeneca vaccine didn't seem to stimulate people's immune systems to quite the same degree as the mRNA or the Pfizer vaccine that used that piece of genetic material to stimulate the immune system, this also indicated evidence that people should receive an mRNA vaccine like the Pfizer vaccine for their booster dose. So this evidence was, as you can see in this figure on the right, presented to the UK government, and it contributed towards the planning and rollout of the booster vaccination program, which was highly effective and had high uptake in the UK and continues to be developed and refined over time, including to today for people living with clinical vulnerabilities. This also produced lots of further scientific questions that we then investigated using the continued results from the laboratory and vaccine efficacy subcohorts within VirusWatch. And this included understanding waning after the booster doses of vaccination. And this also led to some quite important scientific insights, particularly around the fact that receiving a booster vaccine, regardless of your initial vaccination type, appeared to greatly stimulate your immune system and produce a robust response that protected people. And this was a really valuable piece of information. And it meant that no matter what your primary dose was, receiving that extra dose of vaccination had a really significant positive effect on reducing people's risk. So that was a whistle-stop tour through both the VirusWatch study and some of our results from the vaccine efficacy subcohort, which is just one part, but a very important part of the work that we've done. Just before we turn over to questions, I wanted to say thank you again to the many people who contributed to the VirusWatch study. In particular, our fantastic advisory groups who helped us understand the results and communicate them to other people, our patient and public engagement groups who also had a really significant impact on this and also on recruiting people and helping to address bias. And of course, our study participants who we could not have done the study without, and the many people who contributed to the study through their scientific, clinical, and engineering contributions. Thank you very much.